Today, I'd like to talk about cataract surgery, specifically the risks of cataract surgery. So let's go. So today, I'm not actually going to be driving, as this is a relatively detailed and extensive discussion, and it would be safer not to drive. And given that this is a discussion about risks, probably best not to take any unnecessary risks myself. So cataract surgery is one of the most common surgeries performed, if not the most common. And it is also one of the safest, with a success rate on the range of 95 to 97%. Now, you might wonder, what about that 3 to 5%? And we'll get into that. The good news is that if you do not have any other ocular conditions, such as glaucoma, macular degeneration, your likelihood of improved vision after cataract surgery is probably even higher than what I just quoted. Now, let's get the really unlikely, awful things out of the way. Okay, so blindness. Everybody worries about blindness with any kind of eye surgery. The good news is that blindness is exceedingly unlikely, in the range of 1 in thousands. The other thing that people may ask about, since it is surgery, and any surgery that involves anesthesia has the risk of death. Death with cataract surgery, like most outpatient surgeries that involve only an anesthetic in the IV and a local anesthetic, is really, really rare. All right, so now that we've gotten those kind of out of the way, off the table, let's get into the nitty-gritty of cataract surgery risks. During surgery, there are things that can happen, even with a skilled surgeon, even with fantastic equipment. The main thing that most surgeons worry about, though, is that the bag that holds the lens, your natural lens, and the bag that we would like as surgeons to put your new synthetic lens into is very delicate. It's called the capsular bag. And this bag does occasionally tear. It's usually only on the range of 1 to 2% of the time. And even if it tears, we can usually put a new synthetic lens in the bag. Now, sometimes it's not possible to put it in the bag. We might have to put it in front of the bag in what's called the sulcus. We might have to put it in front of the iris in the anterior chamber. Rarely is the bag unable to support a lens at all, and we then have to come back at a later date and essentially sew the lens in. And that's often better to do at a later date for reasons that we won't get into here to limit the time of this discussion. Now, there are conditions that can make capsular tear or rupture more likely. These conditions include certain systemic conditions, such as pseudoexfoliation syndrome, which in general your surgeon would know about beforehand. But medications can also increase the risk of capsular tear. Medications such as Flomax and that class of medications, commonly used for prosthetic hypertrophy, mostly in men, but occasionally will be used in women as well. The reason why Flomax, also known as Tamsulosin, the generic name, as well as other medications in that class, can result in an increased risk in capsular tear is that they can predispose to a condition known as intraoperative floppy iris syndrome, IFIS. What IFIS does is it tends to limit the amount the pupil can dilate, and since as surgeons we need to get on the other side of the iris, if the pupil does not dilate, we don't have a very good view. But not only that, is it can make the iris very floppy. So you can imagine if you were trying to do some work next to a window and the drapes were billowing around you because of the wind, that's what it's like for a surgeon to work with intraoperative floppy iris syndrome. Fortunately, there are things that surgeons can do. We can use specialized gels called dispersive viscoelastics to push the iris out of our way. We can use intraoperative mydriatics, which essentially stiffen the iris and keep the iris dilated. So if the surgeon's aware that someone is using this, then the surgeon can generally make adjustments during surgery and plan for it. Now, you may wonder, if you're taking this medication, should I stop it? And the answer is no. All it takes is one dose. So you could have taken the dose 20 years ago and no longer be using it. It doesn't matter. So there's no point in stopping it, because what's done is done if you've taken this. All right, so fortunately, it's very unlikely that that would happen. So let's talk about the things that can happen after surgery. All right, let's start with the thing that we as surgeons worry about the most, the things that can actually cause a loss of vision or even rarely blindness. Now, the worst would be infection. Infection in any surgery can be devastating, but with surgery in the eye, it can lead to blindness. Infections can progress very, very rapidly. So it's very important that if you have surgery and you have any of the following symptoms: redness, pain, loss of vision, discharge from the eye, you let the surgeon know right away. Okay? This is the type of thing that if it's caught right away within hours, often it can be treated and the vision can be saved. If, however, it's not, then total loss of vision is possible. It's very important that you have a relationship with your surgeon such that you're comfortable calling your surgeon or your surgeon's office any time of day or night after surgery. I tell my patients that if they have a problem at 3 o'clock in the morning, I want to know by 5 minutes after 3. It's that important. Fortunately, this is very rare, so I very infrequently get called or woken up. But a little loss of sleep is a price well worth paying in order to save the eye. Now, what else? Retinal detachment. Retinal detachment is a 1 in 100 risk. So 99% of the time, for someone with a normal eye, it's not going to be a problem. Now, for those with myopia, nearsightedness, that risk could be greater, could be as high as 3 to 5%. Now, if you had that, and that can happen at any time after cataract surgery, so it's not limited like infection, which is generally limited to the first week after surgery. Retinal detachment is essentially a lifetime risk after any surgery on the eye. If you had that, you would know. You would see floaters, as if there were bugs around you, but nobody else sees them. Flashes of light, as if somebody was taking a picture with a camera phone and the flash was on, but no one was doing that. Or a curtain over the vision in your eyes, so you just can't see a certain part of someone's face or the area that you know you should be seeing. Any of those symptoms, you should let your surgeon know. Now, we have a little bit more time on that. Generally, if that's caught within 24 hours of symptom onset, we can generally get that corrected surgically, usually with the help of a retina specialist. So those are really the main things in terms of what can cause a total loss of vision. Fortunately, most of the other risks of cataract surgery do not cause total loss of vision, though they can cause limitation of vision. Early on after surgery, the main thing that surgeons worry about is intraocular pressure elevation, so an IOP spike, as we call it. Essentially, during surgery, a gel is placed inside the eye. Now, that gel is designed to stay in place to protect the structures in the eye. So it can be quite difficult to remove it all, and generally a little bit of it is left behind, which is fine because it just drains out through the natural drainage system. However, that can temporarily kind of clog up or sludge up the drainage system. So it's similar to having a group of people over to your house for a dinner event, and you put all of the leftovers in the garbage disposal and the sink backs up. Now, eventually it flows through, but there's a temporary backup. So the same kind of thing can happen with the viscoelastic gel and the drainage system in the eye. Now, that generally occurs within a few hours after surgery, so some surgeons will see their patients the same day as surgery. That's my personal practice. I like to wait 3 to 5 hours after surgery so that if there is a pressure elevation, it's caught right away. Now, the majority of surgeons will see their patients usually a day after surgery. Some even wait 2 days after surgery. Now, if you have a surgeon who will see you the next day or the day following, if you have severe pain after surgery, so a deep throbbing pain or brow ache, headache kind of thing, you need to let your surgeon know. You should not have a severe pain after surgery. A little bit of discomfort, the sense that there's an eyelash in the eye, that's normal, right? But if you have severe pain, that could be an indication that you have either elevated pressure in the first day after surgery, or if it's days after surgery, then that could be a symptom of infection. But the first 24 hours, pain is usually related to high pressure in the eye. Now, the good news is that high pressure can be detected in the office and generally treated either with eye drops or pills, or sometimes fluid can actually be released from the eye through one of the incisions that was made at the time of cataract surgery. Now, what if you're someone whose surgeon is not going to see you for 2 or 3 days after surgery? Those surgeons will generally give you medications to take from the time of surgery until the time you see them that will work to keep that pressure down. So it's really just kind of surgeon preference. But if your surgeon's preference is to wait a couple of days, as I said, one of the medications that you're taking will most likely be there to address the potential pressure elevation that can occur. Now, what else? The cornea, the very front of the eye, is the first surface that light hits. Now, the cornea will be a bit swollen. Not necessarily the entire cornea, but where the incision was made will be a bit swollen. And that can limit the vision somewhat while that's there. The good news is that the swelling almost always goes away within a few days to a week. There are conditions, however, that can increase the risk that that swelling will not go away. One of those is Fuchs' corneal dystrophy. And this is something that generally your surgeon will be aware of before surgery. People with Fuchs have a higher risk of needing a corneal transplant after cataract surgery. Now, the good news is that with modern transplant surgery, you do not necessarily need to replace the entire cornea. You can just replace what are called the endothelial cells, which do the pumping work. They pump fluid out of the cornea to keep it thin and clear. Denser cataracts can also increase the risk of corneal swelling, which can increase the risk of it not going away. Now, this is one area, and I don't want to get into the femtosecond laser debate at this time, but this is one area where in surgeons who use an older technique called divide and conquer, the femtosecond can actually reduce the amount of phaco energy absorbed by the cornea, and it's that phaco energy that causes the swelling. And so there may be an argument for using the femtosecond laser in that case, in the case of a dense cataract with a surgeon who uses an older technique. If your surgeon uses a newer technique, such as chopping, there's really no strong evidence in the literature that there's going to be a reduction in energy absorbed by the cornea, because the chopping technique was designed specifically to reduce the energy absorbed by the cornea. That's the technique that I use, and so I don't generally use the femtosecond laser. It's fun. It's like a video game. I enjoy using it. I just can't justify having my patients spend $1,000 to $2,000 so that I can have fun, because it really doesn't help me in any other way. Anyway, that's probably a whole nother video that I should do. But let's keep to the risks of surgery at this time. Now, I'm talking about inflammation, so swelling in the cornea. You can also have a delayed swelling in the back of the eye, in the retina, what's called macular edema. Now, this tends to occur somewhere between weeks 4 and 10. And that's why it's important to come back and see your surgeon about a month after surgery. They can do some testing called OCT that can detect that swelling. And if it's there, it can usually be treated with eye drops or sometimes an injection in the eye called an intravitreal injection, but it almost always resolves. There are some conditions that increase the likelihood that this swelling can occur. So diabetes is one. Another is what's called an epiretinal membrane. And so if those conditions are there, your surgeon may have you use anti-inflammatory drops for a couple of months after surgery, rather than the standard, which tends to be about a month after surgery. So we've talked about infection, we've talked about retinal detachment, pressure spike, swelling in the front of the eye, swelling in the back of the eye. One thing that I have not talked about is the lens itself. So when the cataract is removed, a new lens is placed in the eye. Now, I'm not going to get into the risks of the different types of lenses because depending on what type of lens you choose, it will have different risks and benefits. That's another video that I should do, and I plan on doing that. But there is one risk that's true for all lenses, and that risk is what we call refractive surprise. Refractive surprise just means that the power of the lens that was chosen does not achieve the desired refractive goal. By refractive goal, what I mean is generally when someone has cataract surgery, we choose a target. That target could be distance, could be near. That target is where that individual would like to see best without glasses. That doesn't mean that they are going to be free from glasses. It just means that at that distance, that will be the clearest distance without glasses. So essentially, wearing glasses, things are clear. They take their glasses off. Where do they see the best? Is it distance? Is it near? So generally, we target for distance, and most of the time, the lens that's chosen achieves the target. The current calculations and methods of choosing that lens are quite good today compared to what they were decades ago. But they still rely on measurements that are made in the office for the most part. Those measurements are the corneal curvature, the length of the eye, as well as a few other things. Now, if the cornea is not smooth, so somebody who has dry eye, severe dry eye, blepharitis, or other conditions such as basement membrane dystrophies, then the measurements are not going to be as accurate as they should be. And so with cataract surgery, it's just like carpentry, right? If you don't get a good measurement, things are not going to be a good fit. So this is more of an issue for people who have had prior refractive surgery, LASIK, PRK, RK, things like that. They reshape the cornea, and so the lens calculations don't really work all that well with corneas that have been surgically reshaped. So the risk of refractive surprise, which is a very small risk for most people with normal unoperated eyes, is a significant issue for someone who's had prior refractive surgery. And so how can that be treated? Well, fortunately, you can treat it with glasses, you can treat it with contacts, you can treat it with swapping out the lens, or you could sometimes even treat it with going back and getting more refractive surgeries, such as PRK or LASIK. Which choice would be appropriate depends on how far from the target one is, as well as prior surgery, the anatomy of the eye, things like that. Those would all have to be things discussed with the surgeon. One final thing that I do want to discuss is the risk of anesthesia. We should have discussed this when we were talking about surgery, but I wasn't top of mind because the main anesthesia risk is due to a type of anesthesia that I just no longer perform, and that is called a Retrobulbar injection. So the eye itself must be anesthetized during cataract surgery. That is usually done with drops on the surface of the eye and drops in the eye. But it can also be done by placing an anesthetic around the eye or behind the eye. Now, the way that one would place an anesthetic behind the eye is by using what's called a retrobulbar injection, which is essentially an injection that goes under the eye and back behind. You're using a sharp needle to place that. Obviously, a sharp needle could puncture the eye. The other things that can happen is there are vessels behind the eye that can cause bleeding. And the last thing is that if the needle actually pierces the sleeve around the optic nerve, then anesthetic can go into the brain and result in respiratory depression. And that is one of the few things that could actually cause death associated with cataract surgery. Fortunately, most cataract surgeries are done with an anesthesiologist there who is monitoring the respiratory rate and is trained to deal with things like that. Fortunately, that type of anesthesia is rarely used today, although there are situations where it is appropriate, and so it's important to know about that risk. So we've gone through quite a bit today, and it's not an exhaustive list. There are other things that can happen during surgery or after surgery that are quite rare, or even if they occur, are unlikely to result in a loss of vision. Your surgeon will provide a consent form, which will list some of these other things that could rarely occur. My intent here is not to frighten you or to give you anxiety about your surgery. My intent is simply to give you knowledge about the surgery because this is a conversation that's difficult to have in depth in a typical glaucoma practice. As you can see, I've been having this discussion with you now for over 20 minutes, and that's just not possible to do in a busy doctor's office. So my hope is that now that you have this information, you'll feel better prepared, you'll be aware of the symptoms to look out for, and you'll know what it is that your doctor is doing during the postoperative treatments, what he or she is looking for in order to provide you the best possible outcome for your surgery. I hope you found this informative and that you feel better prepared for your upcoming cataract surgery if you are planning cataract surgery. I'm also hopeful that you experience none of the things that I just spoke about, and that your only experience is that you're enjoying much better vision after cataract surgery. And indeed, despite all of the risks that I spoke about, the likelihood that you will simply have better vision after surgery is above 95%. So the vast majority of people do not experience these things and just enjoy better vision. And again, I hope that's the case for you.